So if the blood is less than 7 days old, we call it as fresh blood. And not a request to the blood bank, we get the fresh blood from our pediatric colleagues. They always require fresh blood, but I was talking about the potassium content of the fresh blood and then 2-3 dpg and the oxygen carrying capacity of the red cells. Advantages remain almost the same. Next. Fat cells. I think that picture you saw how much was the volume in a whole blood and what was the volume in a fat cell. So fat cells are just 150 to 200 ml red cells, from which most of the plasma has been removed. So this has a hemoglobin of about 20 grams per 100 ml. Then this is also stored in 4 degrees centigrade. And its storage depends upon what is the preservative solution, the anticoagulant that is used. So it can be up to 42 days. And indications, again, our pediatricians prefer whole blood for exchange transfusions, but literature says even fat cells which are less than 7 days old could be used for exchange transfusion. I think it all depends on what you are used to using. So even fat cells, if whole blood is not available, it could be used. So the question here is, why can't we convert this whole blood into a nice red blood cell cupcake and then use the cupcake? So if we, there are a lot of problems that clinician encounters, starting from the transfusion. We feel it's not very easy because of the high viscosity blood is not passing so smoothly or so flowing so easily in the blood tubings. So if we say yes, we are replacing whole blood with fat cells, I think yes. So here, really, patient is really benefited by reduction in reactions, transfusion reactions that we encounter. This is of course just to say what each of the bags contain. We use 350 ml bags or 450 ml bags depending on the weight of the donor. 60 plus or 65 and above, we always use 450 ml bags and what it contains. Then the preservative solution, just a roll of each ingredient that is there in the solution. Citrate, of course, because chelates the calcium. Glucose sustains the metabolism of RBCs during storage, and the acidic pH is counteracted. The acidic pH counteracts marked rise in the pH that occurs when the blood is being stored or cooled to 4 degrees centigrade. So all these I think we know, and why I think because it prevents the loss of ATP and serves as a substrate for synthesis of adenine nucleotides. Now, most of us use this Segel. So what is this Segel? So this is saline, adenine, glucose, mannitol. This also when we started with the little resistance, adapting to a new change is a little difficult. So now, yes, most of the blood banks have started using Segel bags. This has a blood bag containing CPD and another satellite bag that contains Segel. So this is only for the red cells. So and the red cells get added to the last bag which contains Segel only at the end after we separate the plasma and the platelets. So this is not with the other components. So this must not be used in children less than 1 year, we say, and this provides normal ATP levels. And advantage again here is we can preserve, store and use the blood up to 42 days. That means it is 35 plus 7. It's giving us 7 extended days of survival of the RBCs. Yeah, risk of transfusion here, repetition by transfuse. Is it really required? So weigh the benefits. So if the benefits outweigh the risks, decide. Many people say here, it is the attitude in a domain that counts. So if the patient were to be your child, your wife, your mother, would you have transfused in that situation is the question. So if you say, yes, I would have done it, then only take up. So this is outweighing the risk benefits. This is the risk benefit analysis. Not just keep transfusing, because we do see many clinicians who have issued blood for the particular patient during surgery, and they may not need the blood. So what matters here is they would have paid about 400 and 500 rupees. So what to do? Patient does not require it, and we do not take the blood unit back into the blood bank if it is about 5-6 hours old. So what to do? She doesn't require, but we are looking at 500 rupees or 700 rupees that is paid for the blood bank, and then the infusion goes into the patient. So this is not to that. So it could be a waste. Yes, it could be wasting that unit which that should not be done. And what happens to the fate of re-infused blood? So why people insist fresh blood, fresh blood, fresh blood? In spite of knowing about the GB, HD and the other risks Dr. Gulbarga was talking about. So what happens within 24 hours? Definitely some of the red cells are going to die. So they become useless. But remaining return to entirely normal state and then survive for the normal period. How to predict the viability? How to know that all the cells that we have collected from the donor is viable till we transfuse? So though there are a lot of things that we look at, none of these would tell us about the viability of the cells. And these cells definitely have little more osmotic fragility because they're loaded with lactate, and then there are some changes that occur in the membrane structure. But we should know that even if it is more than 7 days old, so up to 42 days, 75% of the RBCs that are collected that are stored are definitely viable. That means that that is useful. Let us not say blood collected and used within 7 days is the only one that is useful or helps the patient in delivering oxygen to the tissue, the oxygenation. But no, even up to 42 days the blood is useful, but it will be only 75% of the cells that have their or regain their function. Next. So after the infusion, store cells into function. So loss of 2-3 dpg that they said, so that comes in the way. So this decreases the capacity to offload because of increasing oxygen affinity. But 2-3 dpg levels return to half the normal in 4 hours and then normal in 24 hours. So no need to worry. So the transfused red cells, even if they are plus 7 days, so they regain their ability to function or to become normal within 24 hours. Yeah. These are the changes that happen in the stored blood. Next. Yeah, next. Next. This is again, we know like how many days each one could be preserved, that Gulbarga already spoke about. Next. Next. This is only to repeat again about the stored blood. So declining oxygen carrying capacity, but it reaches normal level in 24 to 48 hours, don't worry. So please, if we issue the blood which is 15 days or 20 days old, please use the blood, don't send it back to us. This is in summary about the whole blood. Next. In summary about the packed red cells. So we know how packed cells are more useful and how the other components could be used for other persons, and why not or why we should not overload the patient with the entire whole blood. So let us start using the packed cells more and more. There are a lot of problems that you encounter during transfusion of these packed cells. So we just come out with a solution for that. You could give us your problems, or we have made a list of problems that we have encountered from our clinical colleagues that are issuing this packed cells, and we will be concentrating mainly on paxils, issues related to the paxils. And now, now it's over to Dr. Kavita. We need to know how this red blood cells is separated. The components are separated. We concentrate mainly on paxils. And after that, we will take up these do's and don'ts and problems and solution. That is where I think we could interact and then we could learn from you, and so we also would learn a lot to improve our service that we are getting from the blood banks. Over to Kavita. Thank you, ma'am.
A very good morning to everybody. At the outset, I would like to thank the organizers and our Madam Dr. Shashikala for having given me an opportunity to speak at this CME. So, Madam has taken you through what is the importance of component preparation, the use of component preparation. So, let us try to understand how these components are prepared. So, as Madam said, I don't think most of them would have visited the blood bank, though we know the location and what is going on, the process and all, the exact procedures which are followed in the blood bank. So it is like getting the blood bank onto the screen over here. So first of all, before we go on for component preparation, what type of blood is a healthy blood, or what type of donor should we prefer to make these components or separate the components? So first of all, these are very, very basic. We need to consider a lot of things because the questionnaire is a very long one, but in general, we look at a very healthy donor free of diseases. And these criteria which are taken into consideration for collecting blood are present in most of the population we generally encounter. So the age is between 18 to 60 years. Hemoglobin should be above 12.5 grams per deciliter, and weight criteria, that is more than 45 kgs, 50 kgs and 60 kgs. So 45 kgs we say is the lower limit that should be there. So with the calculation that we need 6 to 7 ml per kg body weight, and with this calculation for component separation, we prefer to have the body weight more than 50 kgs and more than 60 kgs when 450 ml of blood bank has to be used. So for a 350 ml, more than 50 kgs is more than sufficient. And as I said, we look at a healthy donor free of diseases. So the donor should not be suffering from most of the hazardous diseases like HIV, HPSAG, HCV, syphilis, malaria. These are the general 5 standard tests that are carried out in the blood bank. Of course, we don't go on to screen the other diseases because they are, even if they are acquired from transfusion, they can be treated. But these are mandatory to be tested for because of the hazards that they carry, that is HIV, HPSAG, HCV, and the other two. So the patient should not be hospitalized or should not have received any transfusion recently. And of course, fluid extraction. These are all minor things which we tend to ignore, but we should pay special attention to before considering a donor's blood. So no history of recent dog bite or jaundice or typhoid. So after a period of about 1 year, these people would be considered so that they would be temporarily deferred for donation. And no history of consumption of alcohol, though we insist most of the times when the donors are interrogated, they do reveal that they have consumed alcohol. So it is better to avoid collecting blood from such donors. And these blood donations could be carried out at the blood bank, or it could be carried out at the camps, or even there are mobile units available these days where the bus or the mobile unit moves at all places where the donation would be organized, and the donors would just walk into the bus or the mobile unit and donate. So, as Madam has been telling in the previous session, that it is the introduction of the plastic bags which made us help or prepare these components because of different advanced technology which is available, and we make use of principles like centrifugation, freezing and thawing. So let us see how these could be done. So as Madam was telling about the hematocrit, so we all know, so the specific gravity of these different components which could be separated are different. So as indicated in the picture on the right side, we have the layers of the different components, the red cells, the WBCs and platelets, and the plasma which stand in this tube, while the entire blood would be suspended. These components are suspended while they are separated on centrifugation. So based on the specific gravity principle of that is the difference in the specific gravity between different components, we make use of this concept to prepare the components, and of course the centrifugal force which is required to prepare these are different. So basically these are the instruments which are to be set in any blood bank for preparation of component unit, that is the refrigerated centrifuge, which is a prime instrument. Blood bags, of course, they must be there, tube sealers, plasma expressor, laminar airflow, deep freezer, and platelet agitator and incubator. So these are the general instruments which are required for any component separation. So I'm confining myself to how the packed red blood cells are prepared. So the availability of these different kinds of blood bags. So initially, when we were confining ourselves to the use of whole blood, it was only the single bag which was made use of. Here we have the availability of double bags wherein the required component is separated. So when it is double bag, we may separate only plasma from the blood and prepare packed cells and plasma. When it is triple bags which are made use of, we could separate the red blood cells in one bag, the plasma in the other, and the platelet in the third bag. And nowadays, the quadruple bags are being used. So the quadruple bags, especially with the additive solution, will have the main bag wherein the blood is collected, and from there, the second bag, that is the buffy coat bag, which is a small bag, and the buffy coat gets separated in this bag. The third bag usually has the additive solution, that is the Sagum solution, saline, adenine, glucose and mannitol. And the other bag, that is for the plasma, which is platelet poor plasma. So in the double bag, we prepare platelet rich plasma, and in the triple bag, the platelet rich plasma is initially separated and then platelets are prepared. But in the quadruple bag, there is a buffy coat which contains the plasma, the platelets more in number, while the plasma which is formed is platelet poor plasma.